Hi, my name is Lisa Elder, and today I'll be talking about direct payments and the triple aim. As an employer benefits professional and a recent graduate of Georgetown University's Master's in Health System Administration, I dedicated over a year of research to this topic, and today I'm happy to share those findings with you. We'll start with a bit of background on the triple aim and direct payments. Then I'll cover the development and actualization of my project, and I'll end with my final conclusions and recommendations. The triple aim is a framework developed by the Institute for Health Improvement to optimize health system performance. The objectives are threefold: reduce cost, improve quality, and improve patient satisfaction. Let's step back to a national view of healthcare spending. In 2016, the US spent almost $3.4 trillion, or about 18% of total GDP, on healthcare. And this is projected to grow to $5.5 trillion by 2025. Now, boil that down to an employer level. Most of you watching probably have health insurance through an employer, whether it's through your work, your spouse, maybe your parents. If so, you are one of approximately 151 million Americans who get their health insurance through an employer. That's almost half the US population. Boil that down even more to adults not yet eligible for Medicare, it's 60% of the population. The status quo in employer-sponsored healthcare, however, is unsustainable. Increased healthcare spending is outpacing general inflation and economic growth based on trends in premiums, wages, inflation, employee and employer-sponsored healthcare contributions. In the past 10 years, employee contributions alone increased by 75% for family coverage. One thing that remains constant: most organizations still rely on traditional health insurance plans, and this is a problem. The solution? Some companies are turning to direct payments. First, an employer has to become self-funded. They would no longer pay an insurance carrier to bear the risk of their employees' healthcare costs as they would with a traditional fully insured plan. The employer would pay providers directly for healthcare provided to employees and dependents. Some companies hire a third-party administrator or a TPA to process the claims, and some companies enter into direct contracts with providers and health systems. So how common is this practice? It all started in 2010. Lowe's became the first US employer to directly pay a health system, the Cleveland Clinic. By 2017, 6% of American organizations were involved in direct payments, including big brand names like Boeing, Walmart, Disney. They partnered with top-rated providers like the Cleveland Clinic, Johns Hopkins, and Mayo Clinic. By 2020, the prevalence of direct payments is expected to increase to 22% of American companies. The problem is there's not a lot of literature, especially in academia, I've found, about whether these direct payment plans work in achieving the triple aim. CFOs, CHROs, brokers, and benefits consultants are desperate for a solution and want to understand whether direct payments are right for their companies. So my research objective was to assess whether direct payment plans are more effective than traditional insurance plans in achieving the triple aim. And my hypothesis was that they would be more effective in all three realms of the triple aim. I studied a single employer with about 300 employees. The company offered a retail health plan. It was a health insurance plan with no carrier and no network. The company paid healthcare providers directly for services provided to its enrolled plan participants. This plan served as a perfect organic example of a company with direct employer provider payments. My data sources included the open enrollment guide with listed premiums, 6 months worth of medical claims data, and survey responses from plan participants. Now for the results. Starting with healthcare costs. When switching to the retail plan, the most savings were achieved through premiums. Coverage for an employee plus a spouse, children, or family could experience 53%, 59%, or 57% savings in premiums, respectively. That's about $3,000 to $5,000 a year. When looking at the medical claims data, I found that the individual costs of care at the transactional level of service were not generally lower on the retail plan than the traditional plan. In fact, services cost 10% more on the retail plan. This was a pretty unexpected finding, and we'll talk more on this later. Finally, I looked at employees' total possible spend towards premiums and towards maxed out deductibles and out-of-pocket maximums. While the retail plan was more expensive for a single employee, employees that are covering a spouse, children, or total family coverage could achieve 23, 24, and 34% savings, respectively. Again, thousands of dollars could be saved. Most respondents strongly agreed they spent less for services. But notice a contradiction to the numbers we reviewed earlier. The claims data showed services were 10% more expensive on average. So why did most people say they paid less? Perhaps the savings experienced through the premiums was so impactful that they perceived healthcare costs to be lower as well. Or maybe the sample of claims data was not representative of most service costs. Comments reflect people thought they could negotiate a better rate. Healthcare was really affordable and cheaper. They got fair pricing, and many offices gave discounts. Next are the results on the quality of care. Most strongly agreed they received high quality care, and most said they saw no difference in quality on the retail plan versus the traditional plan. For the most part, care was all around high quality. Comments were interesting in that quality was related to access. They got to choose their doctor versus being limited to a network of options. Quality was also tied to transparency. Doctors would tell patients pricing up front because they wanted to make sure the patient was okay paying. Patients were told what services were really needed and what services were considered extra, because providers assumed the patient didn't have a normal health plan that would just foot the bill. Finally, the results on patient satisfaction. Most participants strongly agree they had a positive experience on the retail plan and an even more positive experience than on the traditional plan. I used Net Promoter Score to measure patient satisfaction. Responses were extrapolated across a spectrum of -100 to +100, with positive numbers considered good and above 50 is considered excellent. The retail plan had a score of +57. Compare that to the industry average of a +19 for traditional health insurance plans. That's very significant. Comments related patient satisfaction to the simplified billing experience, the low cost for the plan and for healthcare, and patient satisfaction was also strongly tied to how providers responded to the plan, whether they were eager to learn and help or became frustrated not wanting to accept quote-unquote cash pay patients. In conclusion, hypothesis 1 was correct. The retail plan reduced total healthcare costs, and perception of spend was more impactful than actual spend. Hypothesis 2 was incorrect. I thought quality of care would be higher when in fact quality was reported as the same for both plans. And lastly, hypothesis 3 was correct. Their direct payment plan delivered higher levels of patient satisfaction, and specifically provider transparency around treatment and billing options seems to drive patient satisfaction more than any other factor. This scenario is exactly what we want. Quality is the best thing to stay constant. Most patients were accessing the same providers as before, and quality was already high, so that's the perfect pivot point. Quality can be maintained while reducing cost and improving patient satisfaction. Moving forward, I recommend that employers take action, maybe implement a version of the retail plan to achieve results consistent with this study. This may be of particular interest to the new company Haven that was formed by Amazon, Berkshire Hathaway, and JP Morgan Chase with the aim of improving employee satisfaction and reducing cost. I recommend conducting the same study with a larger sample size to increase the validity of the findings. I'd also like to run this kind of a study comparing more aspects of quality. As you can see, quality was only assessed through self-reported survey responses. Lastly, I like to hear from providers, get their insights, and understand their experience with direct payment plans. If providers better understand the plan or provide feedback on how to improve this type of health plan, all aspects of the triple aim can be impacted. Thank you for your time. If you have questions, please comment on the post or message me directly.